Good morning, everybody, and welcome to this webinar from the Alliance, Implementing High-Value Care for Your Employees. I'm Catherine McLeod, Manager of Product Portfolio and Strategy for the Alliance. We're pleased to have Dr. Michael Tuggy with us this morning for the second in our webinar series about how primary care can be different than what it is today. That difference can move healthcare forward by controlling costs, improving quality, and engaging people in their health. Before we get started, let's go over a few housekeeping items. First off, if you have any issues during the webinar, please use the question box to communicate with us. There definitely will be time for questions at the end, but we want to encourage you to send questions to us as we go through the webinar. So to ask a question, you can either use the questions box, or if you'd like to ask verbally instead of typing, just click on the raise hand, and then when it comes time for questions, we'll call on you. So now let's introduce you to Dr. Tuggy. Michael Tuggy, MD, is a clinical professor at the University of Washington School of Medicine and a practicing rural family medicine physician. He was the director of the Swedish Family Medicine First Hill Residency for 14 years, where he practiced full-spectrum family medicine. Dr. Tuggy is also a member of the American Academy of Family Physicians and the Association of Family Medicine Residency Directors, which he led as president in 2013. And from that leadership position, he joined in on the development of the strategic plan for family medicine that is now being implemented by Family Medicine for America's Health, where Dr. Tuggy is the vice chair of the board. I will now turn the presentation over to Dr. Tuggy.
Okay, thank you very much. And I just want to be sure that my main screen is showing. So let me get that set up here. Okay, well, welcome, and I'm glad to be back with this group again to be able to talk about the 7 healthy habits of advanced primary care. And you know, our last webinar, we talked about some of the challenges in primary care in the current fee-for-service model. And what I'm going to hopefully spend time today with you is just looking at how can you recognize if a practice that you're going to partner with is going to be an effective partner in delivering high-value primary care to your the people that you are responsible for in your population that you're purchasing health care for. So the key take-home points today is that comprehensive payment in primary care encourages high-value care delivery. Purchasing primary care independently frees the practice to serve their patients untethered from the non-value-based secondary care that we see within our healthcare system. And we'll look at how to describe what advanced primary care looks like and how it should and what it should deliver to the population it's serving. What we'll discover is that when you learn about comprehensive primary care payment, how that that there are ways it allows you to innovate that you cannot do in the fee-for-service model, and understanding how payers and practices together can align incentives really is a great way for us to look at how we can lower costs in a way that benefits both the payer, the practices, and the patients. And in order to do this, there really are 7 habits to look for in these high-value practices. So this is what we'll spend our time on, and then I'll be happy to take some questions at the end. So what are the 7 habits of high-value primary care practice? The first one is really centered on access. We call this advanced access scheduling is the terminology that we use within our primary care circles, but what this involves is making sure that patients who need to be seen are seen promptly, which is one of the highest things that patients request when they evaluate a healthcare entity is can they get the care they need when they feel like they need it. And advanced access scheduling basically puts about 30 to 50% of your visits on a given day are considered same-day appointments. So if you're looking at a practice, this is one of the questions to ask them. What percent of your visits do you have on for every provider who's in your group are same-day appointments? So can we get a patient in that same day if they call requesting an appointment? And the way that we use these in our practice is that we actually have 30% of our appointments are same days. And within 24 hours of that appointment, a patient can request a same-day appointment even for the following day. And that allows us to keep those filled, but also allows for a quick response time for somebody who calls, say, in the middle of the day. If we have a same-day appointment open in the afternoon, we can usually work them in still. The other thing is simplifying the scheduling templates. Some practices have quite complex rules about how their providers will see patients, and I mean, I've heard of practices that say they don't want to have 2 complex patients in a row, or they want to have certain specific things. And all of these rules, if you have in your scheduling template for a practice, complicates access. Patients, if they don't fit the criteria for the templating, then they can't get it. They can't use that appointment. And that kind of mentality is meant to protect the provider and not really allow access for the patient. So we feel like that is completely has no value in the long term in managing a practice and schedule. So just having a simple schedule that allows anybody to be seen in any patient slot is the way that a good advanced access schedule is set up. Longer appointments, like I mentioned in our last webinar, 30-minute appointments allow for a lot more things to get done for patients and much better encounters between the provider and the patient. And 60 minutes is an ideal for intake for new patients. Our practice is using 40 minutes, and I feel like that's just barely enough time to get to know the person better. But it really does allow for a good discussion about multiple health concerns and issues that many people come in with, especially if they're establishing care in a new clinic. But a 30-minute appointment as a standard gives you some flexibility, because if, as you're seeing somebody with something relatively simple, it actually gives you some time back on the provider end, which allows you to do other types of care for other patients in that extra time you have. And then also we set up these kind of quick visits, which we, when somebody calls in for something very simple, perhaps an ankle sprain or a bladder infection, something like that, something that can be taken care of in 5 or 10 minutes quite easily, especially with your staff doing a good portion of the visit. This allows us to see people for urgent visits that need to be seen that day. Even if we don't have any appointment slots open, we can at least slip them into one of these slots pretty easily. And then, of course, with advanced access scheduling, you have to have alternative visits available. And what's key about this is actually, and this is something I look for in a practice, if they say they do phone visits, is do they actually schedule them or not? In one of the clinics I operated where we had the direct primary care model, we actually would book in the time in the schedule for 20 to 30 minutes for a patient to call in and discuss their health issues with their provider. And this protected the provider's time for that patient and allowed the patient commonly to be taken care of at the workplace. They'd be at their desk in their office and call into the doctor and go over their health questions or maybe follow up on their diabetes. And that phone visit was a protected time for both the patient and the provider to deal with their health issues without having to actually have an office visit. So how does comprehensive primary care payment support these? Because this payment is really tied to patient engagement. The more engaged our patients are, the more loyal they are to the practice, the more they're going to go there for their care instead of going somewhere else to an urgent care or an ER when they have questions. The first thing they're going to think about is going to see their primary care provider if they've had easy access in the past and enough time to feel like they have built a relationship with that provider. The other thing it does is that I love this idea of efficient use of a visit, not just efficient visits. When you have more time with a patient, you can get many more things done, especially when it comes to things like health maintenance and preventative services. You actually have time to address those issues even after you've tackled whatever acute issues they may have or the things of highest concern to the patient. You still need to have time to address those health maintenance type of issues that need to happen. And then the other thing, of course, is access matters to prevent excess costs. I mean, every time a patient does not go to the practice for their care needs, they're going to go somewhere else more expensive. So creating this open access type scheduling where the patients can get in any day that they need to be seen during the week is really key. And we'll talk about what do we do after hours in the following slide. So the next piece of the next habit is also centered on access, but this is asynchronous access. How does the practice allow for asynchronous communication between the clinical team and the patient? Well, of course, these days, most electronic medical records do have confidential messaging systems tied to the medical record, and that's a very key component to allow patients to reach out to their clinical team that takes care of them. One of the key criteria, though, is that somebody in that team needs to respond to the patient within 24 hours. They shouldn't be left hanging for 2 or 3 days with their email message to their provider. I know that most of our electronic records will have a notice that says, please don't use this messaging system for acute issues, and you can expect a response within 2 or 3 days. But I think that getting somebody on the team, whether it's the nurse, or the triage nurse for the clinic, or even the medical assistant responding to the patient to let them know that it was received and they are going to be getting back to them within another 24 hours with a response is really key to help patients feel like they're being listened to. You can do a lot of chronic disease management through electronic messaging. This has been one of the things that I've seen work incredibly well, following up on blood pressures, getting recordings of blood sugars from patients and making adjustments to their insulin on the fly, basically, instead of waiting for the next appointment, allows the clinical team to kind of correct problems in patients' chronic disease issues very quickly. Patients who are asthmatics, who run out of medications, who need refills or don't know how to use their inhalers, those kinds of issues can be addressed just by electronic messaging many times in order to just make sure that they're getting the care that they need to prevent worsening of their condition. You have to have an after-hours urgent care call line. There needs to be some mechanism for patients to call in and talk to somebody that is tied to the practice directly. And also in that practice, there should be a backup call system so that one of the providers is available for a patient so that they can have a direct call with the physician on call, because that allows them to be to get higher level advice if necessary, and especially for planning a follow-up with that patient, with that provider. And then the other thing is kind of this idea of quick hitter questions. Many times there are kind of standardized questions that do come from patients, and having a good set of scripts for your clinical team about how to deal with those questions is helpful. And then, a good example again here is something like a bladder infection. Patients, many times don't even need to be seen. They don't even need to drop off a urine sample if they are a reliable historian and have had bladder infections before. A nurse can just review that with the patient, make the clinical assessment that they have a bladder infection, and send in the prescription for the patient and have it signed by their provider. And that can be done in minutes without having to actually interrupt anybody's workflow, and it can be done between patients in the clinical day. And then the final thing is, which I like to ask practice leaders about if they say they do electronic visits, is how do you reward providers for that? Is this part of their calculation of their workload? And probably the best way to look at this for a practice that's on value-based payment is, do they allot time for e-visits? I think that Kaiser has a good model that they use with their providers, where they block out an hour at the end of every half-day session for the providers to answer messages from their patients on their confidential messaging system. And that basically rewards them with time, so that they're not just saying you're going to be doing this work when you go home at night, but they're giving them time during the day to get that work done. So again, how does comprehensive payment support this? First of all, if you have comprehensive payment and you're paying a practice in the 10 to 12% of the total cost of care range, they can afford to actually have electronic medical record system. One of the challenges that we see in small practices especially is that they have not been able to afford electronic medical records with the current payment models and fee-for-service. But this model allows for them to purchase one of many good EHRs that are available now, and these have those asynchronous systems built in. And the other thing it rewards the most effective management outside of the visit. So it rewards you for taking care of the patient when they're not in front of you. And so comprehensive payment needs to do that if we're going to actually reduce the number of unnecessary visits in the clinic that are being seen. So habit number 3, care coordination for transitions of care. This is a big piece of care that has been a real challenge in the past for health systems, often because the schedules are too packed with visits that could be handled in another way. But when we have a patient who's in the hospital, transitioning from hospital care back into their home, there needs to be some sort of notification system set up so that the care team and their provider know that they are coming out of the hospital and need to be seen. Ideally, you want to see these patients usually within 1 to 3 days, depending on the severity of their diagnosis and how they're doing at the time of discharge. In the ideal world, there would be a conversation between the discharging physician and the primary care provider, and in some systems they really work on having a direct communication for that. And discharge summaries can do that from the hospital being provided to the provider, but many times there are subtleties that are gained from a conversation, so having that conversation is something that we would certainly like to see happen more often in care coordination. But with these patients being discharged, there needs to be a systematic way of following them up from the hospital. So what that means is, if you're assessing a clinic's process of how they do this, you want to find out who's the person that gets notified for a hospital discharge. How do they handle that notification? Who do they contact within their care team? And if their primary care provider is unavailable or out of town, how do they make sure that one of the care providers on the team is anticipating seeing this patient who's been discharged from the hospital? When we think about which patients are most likely to cost more money, obviously someone who's come out of the hospital, they already have cost a lot of money because every hospital admission is quite expensive. And we want to make sure that those patients don't bounce right back to the hospital again by a flaring of their illness that they were admitted for. So this handoff of care between the inpatient and outpatient sector really needs to be managed well, and it's often best managed, the actual handoff piece, by care management nurses. And so this is a reason to consider, looking at practices. If they have nurses that are assigned to case management or care management duties, they are a critical piece of communicating between the inpatient team and the outpatient providers as part of their workflow to manage these high-risk patients that are coming out of the hospital. So how does this model take care of this? Well, one of the things is that comprehensive primary care, because you're being paid on a per member basis and not on a per visit basis, allows you to carve out time for meetings for your team. And the team needs to meet on a regular basis to discuss high-risk patients, but they also especially need to have time during the day to, especially for hospital discharge patients, for the case management team to be able to connect with the clinical team to let them know who's coming and when they're coming in and arrange those appointments and get them into the clinic within a few days of discharge. These are really high-risk times for patients when they are transitioning out of the hospital, and it's a great opportunity to prevent readmissions, which obviously lowers the total cost of care. Habit number 4 is proactive preventative services. So, we all know that there are schedules of things that we like to get done for patients to make sure that we are getting the appropriate screening done for cancer screening or for immunizations. If they're diabetic, making sure they've had their foot exams, eye exams, other things like that that are part of preventative services for those patients with specific conditions. And the health record that the practice uses needs to be able to track and record these services well. One of the challenges that I have seen with some health systems is that they they may not necessarily be able to extract data out of a note when a service was provided, so the team has to be sure that they're actually recording those services through the health maintenance plug-in that's usually attached to these records. But we want to be sure that they're receiving the services that they need to get, and they're being recorded accurately within the system. So this really means that the care team has to have a systematic way of reaching out to patients, bringing them in for preventative services, and recording that data in the health system so we know who needs what preventative interventions done. And again, this is a question you can ask a practice. Who does this work? How is this managed? What's the workflow? Which members of the care team are responsible to execute on delivering on the preventive care services? And there's several ways of doing this. In some systems, they'll have one person who's kind of a guru for tracking preventative services, or one group of people within a clinic. And then, but other groups will have the PCP and perhaps the medical assistant get the reports, and then they reach out to patients to get the patients in who need to be brought in for those preventative services. One of the things that I've seen happen in our practice that's been a real success is having a thing we call pre-visit preparation. So pre-visit prep is done for every patient visit that we do. And my medical assistant looks at that patient's care needs and what they're due for in their health maintenance. And that is recorded on their visit sheet when they come in. So we know what they need to get done when they arrive. And this is often completely unrelated to the reason why they're there, but having this reminder allows us to get those services done. And we now have a system too where the medical assistants will place the orders in the record so that we cannot even close the chart after the visit unless those orders have been signed. And that forces us to, first of all, deal with it, discuss it with the patient, make sure they're ready to have that service done. And if they decline, we can remove the order. But if they want to get it done, because we can't complete the note unless it's been signed, it allows us to get those things done at the visit time. So that's a great way to capture those things. And again, this is for people who are coming into the office for visits. You still have to have a system to look at patients who are not in front of you in the office as well. And then finally, the vaccine tracking is really important. That you have a good system to track what vaccines have been given to patients, which ones they're due for. The pre-visit prep is great at inserting these vaccines into their order systems. And then having an open access vaccine appointment policy with nursing staff is really key. That any patient should be able to walk in the door and request that their vaccines be updated, and the nurse can see them and give them the injection without any barriers to that care. In the typical fee-for-service model, many times patients would be asked to make an appointment to see their provider just to get a vaccine in order for that provider to be able to bill for that service. So again, comprehensive payment, how does this support healthy habit number 4? It creates incentives for targeting key preventive services. I mean, when you look at what type of incentives you want to create with your practice that you're working with, you want to be sure that you have targets for preventative services and in order to make sure that they are meeting the goals of getting your population appropriately covered with these preventative services. The other thing is it creates an inertia to bring patients in who are not in the clinic. What I've seen so much in the past is that when you're being paid on fee-for-service, it's really hard to think about those patients who are not there. Whereas in this model of population-based care, you are very aware of patients who are not coming in, and you are getting reports regularly of those patients who are due for services and due for follow-up on their chronic conditions. And this pushes you to bring those patients in for those services. Okay, habit number 5, cost-saving primary care procedures. So many of our providers, most of our family physicians especially, they have been trained to do the majority of these procedures that I list here. Skin biopsy, just to determine whether or not something is a cancer or not. Skin cancer excisions, many times they can be treated with a simple excision in order to remove the cancer. Cryotherapy, which is extremely easy to do, but eliminates precancerous and very early basal cell cancers, can be treated with cryotherapy. Joint injections for arthritis in the shoulder and knee especially are common. And then IUD insertions or Nexplanon insertions, which are implantable contraceptions. Those are all things that many of our family physicians are trained to do. And some physicians are also trained in limited ultrasound, which can be a very nice tool in the office to assess masses, breast lumps, thyroid masses, things like that, in order to determine what, if they need to be biopsied, which can also be done under ultrasound in the clinic as well. So getting a good handle on what types of procedures the practices that you're engaged with does is, I think, an important way to assess what their value is that they're bringing to the table. In our clinic, we do things like colposcopy. I do vasectomies, so we add, those are value-added procedures because vasectomies are about $1,000 a pop. And if we can do those within our clinic and not make it a separate charge, just wrap that into the bundled payment, that would add more value to the care we're providing. So the key thing about procedures, of course, is that every time you do that in the primary care setting, you are reducing the referrals out for those procedures. And oftentimes those referrals lead to a whole other office visit by a different specialist, and then you'll be dealing with the specialty charges as well. So how does comprehensive primary care payment support procedures? Well, procedures in clinic take time. If you have a schedule that allows you to have 30-minute visits, you can get many, in fact, most of these procedures can be done in less time than that. And this leads to lower referral expense and provides the time for the providers to do this work. The other thing that I've seen over the years is that procedures create a bonding environment, which is quite different. It's one thing to see somebody in clinics for their chronic conditions and talk about their health issues, but when they need something done to them physically, where they need to have something removed or they need to have a procedure done that could be uncomfortable, it is actually a time where a different level of trust is built. And I find it really fascinating over the years of working with patients, is that patients that I have found an issue that they needed to have taken care of, where we did a procedure to cure it and get rid of the problem, that those patients seem to have a deeper sense of connection with that provider. And that's, I did obstetrics for 20 years and delivered entire families of children for couples, and those relationships were definitely some of the strongest ones because of that delivery experience, even though it's only one day out of maybe, or 2 days out of their life where they had 2 children. It made a huge difference in the trust level that we had just because of that shared experience. And it's also true for other procedures where there may be a cancer and their patient's really worried, and you remove it and you cure them, and they feel incredibly relieved by that. The other thing too is that studies do show that for primary care providers, that doing procedures actually reduces burnout for providers. It's a different type of interaction. It's a different pace during that visit, and it feels like you're doing something very direct and pretty concrete for the patient. So those are key things that where comprehensive payment really does support doing procedures. Habit number 6 is robust chronic disease management skills. And this is what I mentioned in our last webinar too, that the providers in your system, especially the physician providers who may be supervising the clinical team that you're working with, need to be able to manage most patients with chronic conditions without consultation. And this is a list here, kind of the common ones that we see most often, managing hypertension patients and type 2 diabetes, people with patients with stable coronary artery disease, congestive heart failure, and chronic pain. I do want to mention the chronic pain piece because this has become a huge issue, obviously, for us nationally with the opioid crisis. But primary care providers are in a unique position of trust with their patients, and they've actually had much of the burden of managing chronic pain over the years. And there's been a lot of mixed advice that's been given to primary care providers, over the last 20 years that has led to some of the challenges we see today of over-prescribing of medication. And so this is something that we have done a lot of work on, is making sure our training for our primary care team is up to speed and up to date on the optimal management of chronic pain, medication management, using medications like Suboxone to manage addiction and also manage chronic pain in patients who have been addicted to opiates due to provider prescribing, and getting people on safe doses. So having a well thought through chronic disease management program is really key for practices to be successful in managing costs and managing outcomes, improving outcomes for these patients. Again, this is one of those questions I would encourage you to ask about, what percent of your patients with these common diagnoses are being managed completely within the clinic. Many times with our patients with heart failure, you'll occasionally need to follow up on an echocardiogram to look at their cardiac function, or if they're a diabetic who's really poorly controlled, they may need to have a one-time consultation with an endocrinologist. But oftentimes, especially with diabetes, these are behavioral issues. They are not medically complex decisions about what to treat with. It's actually more, how do you manage the behavior of the patient and get them to take their medications? And this kind of leads to the next piece, which is, again, having on-site care management nurses is really a key piece of this. One of the great things about care management nursing is that they spend time on the phone with patients. They get to know the patients as well. They can see them in the clinic to establish a bond with that person. But they basically check in much more frequently than the providers can, and get a sense of which patients are really having trouble with either understanding their treatment or being compliant with it. And using motivational interviewing skills, trying to understand what makes that, what are the inhibitors for that patient's care, are all things that case management nurses are skilled at determining, and then working with their primary care team, and we can help shape that behavior over time. One of my favorite stories about this is a patient of mine who was an alcoholic with diabetes, and we had him on a schedule to contact him every 3 months to see how he was doing with his diabetes care, and he would not come into the office for the longest time. And one of my nurses was talking with him, and it was about 1 year into phone calls with this patient. So I think it was the 4th call she had made, reaching out to him, asking him to come in for his visit, where he realized, he said to her, he said, "Seems like you guys care about me. You keep bothering me." And then after that, he came in for his visit, and within 3 months, his A1C went from 12 down to 8, because he finally got the clue that we really wanted to get him under control. And he stopped drinking as well, which made a huge difference. But it was, I think for him, it was a realization that somebody outside of his home cared about him and his condition, that really drove him to be more compliant. So case management nurses and the care team working together are really key in getting patients to comply with chronic disease management. And again, how does comprehensive payment support this? Well, if you have more time in your visits, this allows you to do several things. Build more trust. They're more likely to be compliant if they trust what you're saying. Allows us to have time for the full team to work with the patient. So it's not uncommon for me to see one of my patients, and then I'll have my case manager come in and follow up after I'm done with my part of the visit, and they'll come in and review the key things that we're doing differently in their care, make sure the patient understands, spends another 10 or 15 minutes with them to make sure they're clear on that, make sure all the instructions are written out so that they understand them. And then that patient gets followed up with a phone call a few days later from the case management nurse as they're making changes in their treatment. So that kind of handoff with case managers is a really key thing, that if you are in a hurried practice with 15-minute visits or 20-minute visits, you're not going to be able to have that kind of time with patients to get that work done. Okay, healthy habit number 7 is population health management. And this is really a new area for many practices, thinking about how they track their population health. And there are many parameters that we have to be looking at as we look at population health. I mean, socioeconomic data, outcomes data based on their clinical studies like laboratory studies are important. Looking at their risk scoring based on their diagnoses. So all of those things need to be part of the electronic reporting system that a practice uses in order to be able to track their highest risk patients. And it's important to know if a practice has a system at which they can receive reports on who their highest risk patients are. And many, many population health departments now have a risk pool where they have the top 5% that are being actively managed by their case managers. And then there's the other 15% that we call rising risk. And both those populations are important. Oftentimes, the highest risk patients are already very expensive. And what we would like to be able to do is to target the rising risk population before they become expensive. And so that rising risk pool needs attention and needs to have time where the case management team and some of the providers, maybe in our system, we use the medical director at the clinic working with the case managers to review those patients and say, okay, who's well controlled, who is somebody that our providers are concerned about who are not yet high risk but are heading that direction because of behavioral issues or socioeconomic risks, things like that. And it is not hard when you ask providers looking at a list of patients for them to identify who do they worry about at night. And that's that's one of the criteria, I think, for determining your rising risk panel is who is it I'm thinking about that I saw today that I'm worried in 3 months is going to be much sicker than they are now, and how do we intervene in those patients? And again, in the fee-for-service model, this kind of time and thinking was not incentivized at all. So having a good risk stratification protocol is really key for the practice. And then the other thing is, does the care team have a regularly scheduled population health meeting with time to plan and execute patient outreach? This is a very good question to ask a practice. Do they set aside time to do this? And these meetings can be, of varying types. Like in our clinic, what we do right now is we get reports sent out to each provider for their patient panel, and that provider sits down with their medical assistant and they walk through that report and decide who they need to bring in. Who is it that they're concerned about? And often the medical assistant and the provider together can identify those people very easily and get them called into the clinic for care. Another model, though, too, is for your very complex patients is having case management rounds where you bring in a much larger group in the team. In another clinic I operated in Seattle, we had, at that meeting, we had the providers, we had the team nurse, we had the social worker, we had a psychologist, and even our pharmacy, we had pharmacy interns working in our clinic to look at the patients that are costing us $250,000 a year in healthcare costs, and look at how can we intervene with these patients. What are the things that they need? And oftentimes it was a complex set of responses that needed to be put together, and by having frank discussions about what we needed to do as a team and making those assignments, we were able to get those things done and prevent further poor outcomes for those patients. And then finally, population health really should be looking at quality improvement. We need to be able to look at our practice and look at what's working well, look at outcomes of what we're doing, and do rapid cycle quality improvement processes within a clinic. So, important question to ask a clinic is, what is your QI process? What type of model do you use? Are you doing a PDSA cycle? What type of structure do you have to your QI process to make sure that the practice is introspective, looking at how they're doing things and looking at how they can improve? Again, comprehensive payment really supports this. If you're receiving 10 to 12% of the healthcare dollar to support your team, you can actually fund the EHR you need and the data extraction tools to get the data you need for your risk management. You also have you can use your time for leaders to direct population health efforts. And it really does support quality. And again, when you look at incentives for a practice, if you're going to incentivize your partners you're working with at the clinical side, finding the right quality markers is really going to be important. And I would draw your attention to a summit that was done this last year called the Starfield 3 Summit, which was something that Family Medicine for America's Health helped put together. But it was a summit looking at metrics that matter. And it is, if you Google Starfield 3 Summit, you'll be able to find some of the key documents there. And in one of those documents, it outlines what are the most likely quality metrics that are going to pan out to be the best metrics looking at clinical quality for outcomes measurement. And we want practices to be held accountable for quality, but we want to make sure that the measures that we're using really matter for patient outcomes, and they're not just a surrogate that is ineffective at really determining quality practice. So those quality metrics are supported if you have proper incentives built into your incentive plan for the practice you're working with. So the last thing I wanted to touch on was, what does an advanced primary care team look like? And obviously, the larger the clinic, the more resources you can bring to bear to fill this team out. But clearly, you should have some physician presence in the clinic. I think that it is critical to have somebody with 10,000 hours of training in order to support the care team that's there. So, we are strongly in favor of having a physician, either an MD or DO, primary care physician, as a part of the care team. Nurse practitioners and PAs are incredible assets for a clinic because they can provide great primary care alongside their primary care physician cohorts. But having the backup for someone to ask questions to and touch base with is really key. In our clinic, we have a fantastic nurse practitioner and a PA, and we regularly talk about cases throughout the day, and we bounce things off each other. But having that interaction where you can actually have someone else's mind in around a case is really an important part of good practice. Clinical team needs to have a nurse, triage nurse at least at the clinic level, and medical assistants who work with that nurse to get patients prepped and also work on the population health and preventive services work to be done. Clinics need to have case management nursing. It is not something that you can ignore. And if it's a very small clinic, the clinic nurse could do both of these things, to do some case management along with their work role as a triage nurse for the clinic and the lead RN. However, they're not going to have a lot of time if you have a lot of complex patients to manage that population. And I think it's important that clinics really invest in case management nurses to do a lot of the complex case management that needs to be done. Obviously, you need to have schedulers and a communications team, so people who get patients set up for appointments, but also help with outreach to patients, to contact them, to get them brought into the clinic when they need to be seen. You need to have administrators who run the clinic systems, obviously, but I think these days your administrator needs to have good data analytic skills and be able to get into your database, learn how to extract data, learn how to pull reports, and provide those for the team. So that is a skill set I think it's important to look for your administrative team. Behavioral health is obviously a major part of primary care. A large Kaiser study done decades ago now looked at an investment of $1 in behavioral health saved about $7 in downstream healthcare costs. So having a psychologist or a nurse practitioner with specialty training in behavioral health is a key thing to add to your practice and to look for in a practice you're partnering with. In our practice, we had psychologists with doctorate degrees in our clinical system, but we also had a psychologist who was just a master's level psychologist doing counseling as well. And then finally, other add-ons that we've talked about in the last webinar, that adding things like physical therapy or having a pharmacist within your group, if you have a large group that can support the workload of a pharmacist, these are things to definitely consider that could be significant cost savings downstream by having those services provided within a clinic. And those would require probably an additional charge or add-on to the monthly payment for on a per member per month basis, but it would not be very much to get the value out of physical therapy or physical trainers within your clinic. So this summarizes those 7 habits, and I think that looking at access is a huge issue in the various forms of how we look at that. Care management, care coordination is key. Preventive services need to be really robust and have a coordinated system for making sure those are being delivered. A good procedural scope within the clinic. Active chronic disease management done by providers and by the care coordination team. And then, again, like I mentioned before, just population health being a key aspect of what we carve out time for within the practice to make sure it gets done. So as a payer, there are ways for you to assess a practice to make sure that they can take care of your population. The more of these 7 healthy habits that the practices have that you are dealing with, the more of those that they're doing well, the more likely they're going to significantly lower your cost of care. And if they do all of them well, you're going to have a profound drop in your cost of care. It does cost money at the primary care level to do this. So being sure that they're funded at an adequate level is going to be a key aspect of making sure that practice can function, to have the necessary staff to do the population health work and case management work. Comprehensive payment really does align these incentives well to provide the highest value care to patients, payers, and providers. And so the value equation is really impacted by this whole scope of practice, and payment should be adjusted to match that scope, to make sure that the practice is being rewarded for having a broad scope of practice too. Okay, any questions? I think we'll have probably a few here.
All right, so thank you, Dr. Tuggy. That is a lot to consider. Some of the questions that we have relate to an employer considering, well, how the heck do I go about bringing this or ensuring that this is available for my enrollees? So would you feel comfortable, would you be able to talk a little bit about the dynamics of the possibility of being able to get this type of care from an established practice that is currently functioning as a fee-for-service versus bringing in a new vendor that is specifically set up and designed to function under this sort of structure?
Yeah. That would be one of those conversations that you would have to have with the practice leadership, because many practices right now can do this type of work, especially, many of the family physicians I work with around the country, they feel hamstrung by the current model, and they are ready and able to do more. They would love to do more for their patients, especially with population health work, but without any payment or incentive to do it, they find it, financially, it's not, there's no reward for doing it, and it's hard to keep your clinic open if you cut your visits down from 20 visits a day down to 12 in order to make more time for patients and to do these 7 healthy habits. But my experience is that when you take physicians out of that environment, you change their practice model, it is so easy for them to do that because it feels right to them. It feels like they're providing better care and they have the time they need to actually do more for the patients when they come in for a visit. And so the transition is not so hard, but if you're dealing with an existing practice, it depends on, what that employer is bringing to the practice and how many patients in that practice are going to be converted to this new model. So if you have a practice with 10,000 patients and you have, 4,000 patients who are going to suddenly be on who could be on this new model of care, that practice will change over. They will change what they're doing in order to get the comprehensive payment and be able, if 40% of your patients are on this new model, it is much easier to get your care team to shift its delivery model to this more advanced care model than if you only have 10% of your patients in that model. So, I think if an employer was looking for a partner, the more employees they have that can fill out a practice. So if you have a 3-physician group and they would have maybe 4,500 or 6,000 patients in their panel, if you were able to bring them 5,000 patients, your employees and their dependents, I think that group would be very likely to jump on the opportunity to switch over and do this model differently. There's definitely it would be a transition for that practice, and part of the work that I do is I work with practices and the practice leaders in the practice to look at how to do that kind of transition. And it is a big part of making that step is converting the practice from a fee-for-service model to a value-based model. But it can be done, and it can be done quickly, because it does not take long for the provider and the care team to realize that this model of care makes much more sense than the fee-for-service model.
Yep. Do you have any thoughts or comments about bringing a vendor into a marketplace, a vendor that is based in the kind of direct primary care approach or the comprehensive primary care payment approach, and establishing that if the healthcare delivery systems aren't able or willing to make a change?
Yeah, I mean, I think that if nobody's willing to make the change locally, then bringing a team in, a vendor in, but that vendor's going to have to hire people locally to do the care delivery, and so I think that's going to be the big challenge is finding the physicians and nurse practitioners to join this new practice in order to deliver the care. But if it's a small enough patient panel, if it's 2,000 or 3,000 patients, something like that, you could certainly finding a provider and a nurse practitioner and a nurse, to manage those patients. I think that a vendor could do that very well, because if they've already established the model and they get it, and how to deliver this way, deliver care this way, then they can build that team out, and just implement their system. So I think that would not be hard to do. You just have to find the people, and I think that would be the biggest challenge. However, I can tell you that the interest in direct primary care is very high, especially with younger physicians. And if you're able to contract, get the physicians aligned and signed up to work in a certain area, they can certainly bring that model in very quickly. The other thing about, I think, a vendor too is they would. I think a lot of vendors, like some of the vendors I know of that are interested in doing this work, they already have built their infrastructure. They have the electronic record, they have the systems in place, they've already done this with multiple teams. So they would bring that experience and know how to build that team and teach them how to do the population health work that they're doing much more easily than somebody who's doing it from scratch.
Yep. So this next one, so in many of the markets where our webinar attendees are located, there are integrated healthcare delivery systems. So it's not just primary care, but also the specialists as well. So it's the structure. Yep. So it's a payment structure that is for the entire system, not just for primary care. Like, what would you say to a healthcare delivery system that operates in a fee-for-service model that says, we do these things?
Mm-hmm. Yeah, and that's why I think that's where it goes down to, when they say they do them, then that's where you ask the more pointed questions, like how is your scheduling really work? How does it really work? And how does your care team actually do these types of population health activities? And how much time do you spend with patients when they come in for a visit? Because I think most fee-for-service practices are operating on a 15 to 20-minute schedule cycle for their providers, which is a lot different than the 30-minute visit as far as how much gets done. And there's no allotment of time for population health activities. They may not have a case management nurse attached to their clinic. There's just a lot of things that they can't do, they can't afford to do with the fee-for-service model. So I think it's going to be challenging to find somebody who's really doing the 7 habits effectively if they're on fee-for-service. So, and then the other part of it too is that, just because a health system has it's an integrated system that's fee-for-service based, there's no reason why the primary care group could not be the primary care services could not be contracted separately, and then the rest of the services have a health plan design that covers the secondary, tertiary care, and pharmacy benefit management as a separate contract. And the real disruptive part of this is that if you can get a primary care entity to take care of your patients in this way, and they're part of a larger group, and this is something that the current group I have is struggling with right now, that primary care group is going to become more effective in what they do, and it's going to lower the downstream revenue for the rest of the system. So it creates a complex internal problem within a medical group, because if I do my job well as a primary care physician, then my specialty colleague is going to make less money. And that's a very frank discussion to have with the practice leaders if you're going to do this, because, and I think, enlightened, practice leadership realizes this needs to happen for us to be successful in the long term in lowering the cost of care and providing value. But it is going to either you lower the specialty payments and salary or opportunity to bill fee for service, or you just have less specialists who are busier doing just specialty work. And obviously the latter would be a lot smarter use of the resources that we have with specialty care. But I think that is definitely a dynamic when you talk to a multi-specialty group that you need to be very aware of, that the primary care team could actually lower the overall revenue for that medical group because they're being more effective.
Well, thank you so much, Dr. Tuggy, for your time, your insights, your knowledge. Just in terms of kind of next steps at this point, we will be sending out a follow-up email for the webinar attendees. We'll be sharing the slides from today's webinar. And watch in that email also for a link to sign up for updates from the Alliance as we bring you more information about high-value primary care and how that can move healthcare forward, and how employers can take advantage of this or put it in place for their enrollees. Watch also for information about potential future initiatives from the Alliance to be able to identify and bring high-value primary care to our members. Thank you all for your attendance today. Thank you, Dr. Tuggy, for all of your work and your help with this. Have a wonderful day.